So Portia Singh is the co-founder and CTPO of West, a home-based prevention care platform that she built for Medicare and Medicaid populations. And yes, she also architected the technology herself. She holds a PhD in biomedical engineering from Carnegie Mellon, spent years at Philips in AgeTech, and holds three US patents. When she's not building healthcare platforms, she's coaching youth soccer on the weekends, which, if you think about it, is not that different from what she does professionally, right? For it, getting people to work together towards something that actually matters. And with that, Portia, it's all yours. Really looking forward to this one.
Thank you so much. I'm happy to be here talking about a topic that's near and dear to my heart, and that is technology for older adults. Um, we will spend the next 10, 12 minutes talking about trust, aging, and AI, why the adoption window for AI technologies is closing faster than we think. And hopefully you'll come out of this um, with hope and actual steps you can take in order to make sure your teams are thinking about older adults when you are developing health AI. I'll go and basically wanted to spend some time just saying, I spent my entire career answering the same questions, same five questions, really. What do older adults need to age safely in their home? Can technology address those needs, and which ones? Have we built the technology that meets the needs and can actually be used by the intended audience, that older adult? Will older adults incorporate and use the technology in their day-to-day lives? It's one thing to deploy it to them, it's another thing for them to actually incorporate it and use the technology. And then lastly, what barriers of use exist and what can we do to eliminate them? So the good news is that older adults are not adverse to technology. In fact, 99% of 50-year-olds and older own at least one tech device. And a lot of times that tech device is a smartphone. So 90% own a smartphone now. Also, when it comes to Medicare, and this is traditional Medicare users, 1 in 4 Medicare users had a telehealth visit in 2024. There's been a lot of increase in usage of technology by older adults. It may still be lagging in the more innovative, newer technologies. However, there's been so much work on just helping older adults incorporate and helping innovators deliver technology into the home, specifically for health reasons. However, there are still a lot of barriers of adoption by older adults. The AARP released a report in 2026 about tech trends for adults age 50 plus. And trust and privacy, specifically data privacy, bubbles up as the top barrier to adopting technology. And, as a foreshadowing, it does not get better with AI. But, as I mentioned before, older adults are open to using technology. And really and truly, we can summarize the barriers as privacy, complexity, lack of support, and the cost of the technology as being the biggest barriers. That said, we've been doing a lot around this, and we have been able to make a lot of different strides in the last decade for understanding how to successfully deploy technology to older adults. We've been designing with older adults and not just for them. We've been designing tech that fits in their lives, practicing mindful data collection. So collecting only what we need in order to deliver the service or deliver the experience to that older adult, thus breaking down some of the barriers to data privacy. We've been much more transparent around technology's value and its limitations. I remember when I was at Philips in the connected aging group and Amazon Alexa came out for the very first time. Um, there was a lot of interest and a lot of promise for that technology so that older adults can use their voice to interact as a user interface. However, early on, it was very, very hard to break through that barrier of what data is being collected and that implication with respect to privacy and security. So that was really I guess that was around, I want to say 2015, 2014. And now I am working in the Healthy Home Lab at University of Pittsburgh part-time to help them get technologies, including smart home technologies like voice assistants, into the homes of older adults. And then lastly, embedding education, training, and support into the deployment. It is not enough to just deploy a technology without understanding the real digital literacy gaps with the older adult population. And we've started to do a much better job at incorporating or anticipating the educational needs and then incorporating that into our product delivery. I just want to give a plug to the University of Pittsburgh Healthy Home Lab. I am an adjunct faculty there and also work with faculty, staff, and students to help commercialize smart home and digital health technologies into the homes of older adults. We've been working on incorporating smart home technology into home modifications as well as into public housing. So I highly suggest you take a look at the work being done. But just like the Healthy Home Lab, there are other laboratories and other organizations around the country that are really championing how we interact with older adults so that we can innovate with them. Now, let's add AI to all of that. AI, unfortunately, comes with a bit of a reputation, and that reputation is creating this trust gap that just is threatening the progress of technology adoption in older adults. Media stories, I'm sure you've all seen some, where AI researchers are sounding the alarm about different technologies. Anthropic, for example, with Claude, they had previously talked about a model that was too good to release or too dangerous to release when it would come into if it were to come into the wrong hands. And then even just in the last day or so, they released their most capable model, Fable 5, and the pace at which AI is growing is outpacing even highly technical savvy people who are accustomed to being early adopters in technology. So now think of the 75-year-old woman who's in her home and her doctor just said, hey, maybe you should use this this sensor, and all the insights are going to be summarized for you with AI. That might be scary. 77% of older adults that were surveyed in a recent AARP study worry that they might personally become victim of AI fraud. 84% are concerned specifically about scammers using AI to generate fake voices. And there's been a lot in the media about fake deep fakes when it comes to not just imagery, but also voice, and being able to take a small snippet from someone's voice and create an entire scenario around that could be used for nefarious reasons. And the worry is real. There's been an increase in reported fraud losses by older adults, 60 plus from 2020 to 2024. So in 4 years, we went from $600 million lost to $2.4 billion. And that's only in the reported losses. The measures for non-reported or the anticipated loss is far greater, closer to 10 billion. The trust bottleneck for healthcare AI is inherited from everything else that we see in the media. 92% of older adults want to know if a person, if information is coming from a person or from AI. 74% would not trust AI generated health information. About 20% lack the confidence of spotting misinformation, which is a huge issue. And there was a lot of media about misinformation around the presidential election in 2024, and that skepticism has carried into all uses of AI, including healthcare. And about 66% have a low trust in responsible use of AI by health systems. So 66% of older adults do not trust that the health systems can use AI responsibly. And it gets even worse. 58% of the users surveyed, of the older adults surveyed, do not trust that the healthcare system will ensure that AI will not cause them harm. And so when we're looking at what is the primary reason for our medical professionals or for healthcare is to, we all have heard this do no harm. 58% of individuals, older adults, are not convinced that the health system can ensure that AI will not do them harm. So all in all, that adoption window is closing, and these bad first impressions can lead to older adults opting out permanently from technologies that could fundamentally improve healthcare delivery, but that is currently changing the way we think about healthcare delivery. But it's not all bad. There's a lot of things that we can do right now to slow that progression of this adoption, adverse adoption. And a lot of these principles are rooted in what we have already learned to do with delivering other technologies. So first and foremost, partner with patient advocacy groups and community health groups. It is so important to understand from the user what they need and what their concerns are with the technology at all phases of design. This includes looking at a full range of ages in your user research from day one. A 60-plus-year-old or a 60-year-old will look very different than an 80-year-old, particularly in, there will be, of course, an overlap, but when we're looking at older adults, we cannot look at them as a monolith because the needs and the abilities change as we grow older. So making sure that we have groups that can represent the entire age span of older adults is key. We want to treat consent and transparency as a design principle and not an afterthought. Disclosing AI in plain language is very important in generating trust in the system and also trust in you as a provider, a vendor, an agency, wherever you're looking at, wherever you're coming from with respect to the healthcare industry. Building trust, transparency is one of the first steps to doing so. And also respecting when users say no. We have to have a fallback for if someone says, no, I don't want to do that. We've seen some of this bubble up in the job market, in the hiring market, where people can opt out of having their resumes read by AI. Now, when we're thinking about healthcare, we do not want to accidentally increase health disparities by not being able to provide alternative options for when an older adult opts out of AI. We need to educate from both sides of the table. Yes, we need to educate the older adults and their care partners on use of AI and what it can do. But we also have to educate teams who are building the technology, medical professionals who are potentially suggesting the technology. AI education needs to happen holistically because there is gaps on what it can and what it can't do, and what the capabilities and what the risks are. And then lastly, building with ethical and safe use as a design constraint. If you cannot accomplish the task, especially when it comes to people's healthcare, we are bound by HIPAA regulations and other compliance laws, but really baking those principles in on day one, that if you cannot do this in a compliant, safe, and effective way, that we do not do it. And that is sometimes a hard pill to swallow when you have an innovation where you really want to push and go fast. And so there's been a lot of work on this, and this is one of my last two slides. But there has been an effort for creating international guidelines on trustworthiness and deployable artificial intelligence in healthcare. And so there is this framework called Future AI, where you want to, ensure and build with the end user in mind, and incorporate fairness. So the AI should treat all patients equitably and without bias. Two things that AI has come under scrutiny about for very real reasons and have had very public mishaps. Universality. So AI solutions should be applicable across different healthcare contexts and populations. It really does add complexity if we continue to have point solutions. This is also in the broader technology perspective when it comes to healthcare. But we also need to consider that also in AI. Traceability. It should be possible to track how AI systems make decisions. A lot of us it's very easy to deploy AI as a black box. And in healthcare, and in order to build trust, particularly with older adults, making sure that we know more about how these decisions are made can have life or death consequences. Usability. The AI tool should be user-friendly for the healthcare professionals, for the patients, for the administrators. We could deploy health AI in all facets of what we call the healthcare system, including with payers, with providers, with any entity that touches the health of a user. We want to make sure that those tools are user friendly for them. Robustness. The AI system should perform reliably under various conditions. How does your AI stand up to confusion by the end user? Can it recover? Can it avoid hallucinating when it does not understand what the user is asking? And then explainability. Patients and clinicians need clear explanations on how AI arrives at its conclusion. So that's also a part of traceability. But once you trace it, you need to be able to explain to these individuals how it comes about. All right, so what now? I have 4 questions that we as innovators, as wherever you are in the healthcare AI community, could ask when you're thinking about designing AI tools and solutions for older adults. The first, representation. Who did we test this with? And did the testing population look like our target deployment population? It seems basic, but sometimes we get caught up with things. We don't pause and say, was this actually tested in the user base that will benefit the most? Agency. Where does the user, the older adult, learn that this is AI? And what happens if they say no? So really not taking away agency from the user to make a decision on whether or not they want to use AI. Support. Can the user navigate this alone, or do they require a care partner? And then lastly, governance. What do our team and partners need to be trained on so that we do not unintentionally violate the trust we're trying to build? So in conclusion, tech adoption in older adults is hard. It has been hard. It is hard. It's hard. But and AI is making it harder. However, there are solutions out there. There are frameworks out there. The silver lining is that AI could really help impact in a positive way the health of older adults. And the solution that I suggest is just being trust obsessed and building with the older adult in the loop, and that will set you up to be in the best position for technology adoption. So thank you for the attending, and thank you for your time. Manan, I guess we'll
Thank you
turn it
so
over to
much,
you.
Portia. You can stop sharing your screen. Yeah, we all have parents, grandparents, and sometimes had grandparents. Sounds like a very interesting area, and we're all headed towards this direction, uh, hopefully in a nice manner. So seems like a very hard problem, and I'm very glad that people are looking at it so deeply. I don't have a question. I was like, okay, this is hard. Like if I recall stuff I had to get my grandmother to do or just get my father to get off the sofa and walk, and you're talking about leveraging AI. Like, does anyone else have a question? We are sort of out of time too. If it's okay, we go like 5 minutes overboard?
I'm fine.
Okay. So if someone has a question, wants needs to leave early, I'll let them go first.
I do have to get going at the top of the hour, but I just wanted to react that really agreed with a lot of what you said. And I'm thinking of when I'm seeing patients in clinic and family medicine, even just doing a consent for like an AI scribe tool,
Mm-hmm.
especially with older adults, they just freeze up often. And it's like they don't understand exactly what I'm asking, and often there's a lot of fear. And so it's like it can take real time to establish that trust. And I feel like the framing is really important. I'm interested if you've seen any literature. Like if I say this is for me to help me take notes, people are like, oh, of course, if it helps you, that's very different than here's an AI tool that will record you. I'm interested if you've seen anything like that
No,
addresses that.
that's a great point. And funny enough, that has been a issue for a long time, because even with dictation notes, using machine learning was I really do think that the word AI is right now carrying a lot of stigma. Where I would say, even with consent forms, it may be worth passing that through a patient advocacy group to understand where is the language falling apart, because you can very much describe it as a tool that dictate takes in the voice and transcribes it, and it's going to be used by X, Y, and Z. Now if it becomes, oh, it goes straight into the EHR and it's now shared amongst any touch point that they have with the healthcare system. That's very different than, my doctor is sitting here and this is so that she can pay attention to me while, so those are two very different use cases. And I think that it deserves, or it may give way to someone taking a pause and saying, hey, how are we actually using this? Is it really just for my purposes, or is it going to go into a system where even though I'm the likely user to use it, it is accessible to other people? And whether or not the consent language actually explains that appropriately.
Thank you. I'm sorry I have to go, but nice talk.
Thank you so much.
Thanks, Kate.
Yeah, I had a question kind of related to that. So yeah, I feel like AI, there is like a bias right now for sure, but like what kind of I was thinking about is that AI is such a broad term, and so like a lot of risk scores, for example, like that use logistic regression could be considered AI. And so like at what I guess how do you think about educating, older adults or just patients in general? Because like hypothetically, you could have to tell them about every risk score, just really
Of course.
simplistic things that like aren't really what,
Yes.
are considered AI now. And then so on top of that, like so I do clinical decision support work, and I've seen like kind of different data, like for breast cancer CDS systems, where patients actually like are really okay with having mammogram review via like an AI tool in combination with like a human. So I just that was a different population. I don't think it was like older adults. But I'm just curious, yeah, what you think.
No, that's a great point. And I shake my head because I've been doing AI for decades now, because machine learning is a subset of AI, and AI is kind of categorically a area of machine intelligence, right? And so the terminology right now is overemphasizing your chat GPT. Like when people say AI, they're thinking about a chatbot or chat GPT, or, those consumer solutions that are, free, or, that have very little guardrails. So when you're now putting that into context of healthcare, what a person is hearing is that, oh, you're using that thing that hallucinated that I heard about on the news for my healthcare. And that's just not how AI is deployed in healthcare. And so to your point, clinical decision support is basically AI 10, like that's what we called it 10 years ago. And of course, right now that's still a valid topic, but that title of AI has overtaken that. And so I think that, to your point, the broadness of AI, it's really to get down to what are we going to do? What data is it? Is it de-identified? Can it be traced back to me in any meaningful way that puts me at risk? And what is the value? Because you could tell so many different people, oh, I'm going to, like, for example, Catherine's example about the notes. They might not see as the value of the notes for the doctor's own personal, recall, but they may see the value in, oh, I just got this mammogram, or I just got this scan. They have millions of other scans. If they push it through this AI, they may be able to find anomalies that the human eye can't see at this. So it's really a marketing problem. And I hate to reduce it to that, but there's a huge marketing problem for healthcare AI, and it's brought upon because of how prevalent it is in the consumer space. I would say, continually advocate for, making sure that everything is built appropriately with the appropriate governance. And then at that point, in context, do the education and the understanding for what AI is doing in that context, because they will go back home. There may be a media report, and you don't want to undo that. The good thing is that older adults are still very, very, very much trustworthy of their clinicians. And so there is an opportunity to leverage the clinician. That's why education around the entire board is important, because they and then the family caregiver or care partner are two entities that have a lot of influence on tech adoption by older adults. They also, if they will, one thing about an older adult that I found is, as soon as you say camera in the home, shut down. But if you lead with the value and then say, but to get that value, we have to place a camera, but this is the security layer. This is how your data is, they will do it. And time again, you recognize like, oh, we're going to put a camera in your house. Absolutely, it's dead on arrival, right? But if you say, we've noticed you've been falling, there is a tool we can use that will, be able to see how your gait is changing and give us a risk score on your, if you might be at higher risk of falling. There's a camera. It's only, taking video of your home. We have it. This little box is going to process it here. There's a lot of ways you can explain it to an older adult, and frankly, anyone. There's so many people who are below 65 who have no understanding of, how this stuff works and whether or not it would help them. So it really behooves us to think about, how do we explain it to our grandmother and then apply that to design of AI healthcare in general, because health literacy is very low across the board, and so is digital health literacy. So it actually would help the entire digital healthcare AI, not just the older adult.
Cool.
Thank you so much, Portia.
Thank you.
I guess just helping everyone wrap up since we've gone over time. Let's continue the discussion on Slack.